Welcome. In this session, we'll walk through the inpatient management of community-acquired pneumonia, or CAP. Our goal is to develop a practical bedside clinical pathway that helps guide decision-making from the moment a patient presents to the hospital until they are ready for discharge. The first and perhaps most important decision is determining the appropriate site of care. Patients with PSI classes 1 and 2 or ACURB 65 score of 0 are generally suitable for outpatient care. Patients with PSI class 3 or 4 or a CURB 65 score of 1 to 2 typically require admission to a general medical ward. Those with PSI class 4 or 5 or a CURB 65 score of 3 to 5 should prompt consideration of intensive care unit management. However, scoring systems are only part of the story. Certain findings mandate direct ICU admission regardless of the numerical score. These include septic shock requiring vasopressors and respiratory failure requiring mechanical ventilation. Patients should also be admitted directly to the ICU if they meet 3 or more minor criteria, such as a respiratory rate greater than 30, a PaO2 to FiO2 ratio below 250, multilobar infiltrates, altered mental status, uremia, leukopenia, thrombocytopenia, hypothermia, or hypertension requiring fluid support. Remember this principle. Treat the patient, not just the score. The shifting microbial landscape. The expected pathogens change dramatically as disease severity increases. In the general medical ward, common pathogens include Streptococcus pneumonia, respiratory viruses, Mycoplasma, chlamydia, and Legionella. In contrast, patients requiring the intensive care unit have a substantially different microbial profile. While Streptococcus pneumonia remains important, we become increasingly concerned about Staphylococcus aureus, including MRSA, and gram-negative bacilli, including Pseudomonas. This shift has major therapeutic implications. The move from the ward to the ICU changes the entire empiric calculus. ICU patients are at greater risk for rapidly progressive and potentially necrotizing pathogens, which standard beta-lactam therapy alone may not adequately cover. Always let disease severity influence your differential diagnosis and antibiotic selection. Slide 4, profiling high-risk phenotypes. Before selecting empiric therapy, actively search for risk factors that suggest MRSA or Pseudomonas. For MRSA, important clues include known colonization, a prior infection, gram-positive cocci in clusters on sputum gram stain, recent hospitalization with intravenous antibiotics, end-stage kidney disease, crowded living conditions, injection drug use, and especially necrotizing or cavitary pneumonia. For Pseudomonas, look for known colonization, prior infection, gram-negative rods on gram stain, hospitalization with intravenous antibiotics in the preceding 3 months, frequent COPD exacerbations, chronic steroid exposure, and structural lung diseases such as bronchiectasis or cystic fibrosis. The key takeaway is simple. If any strong risk factor is present, the empiric regimen must be expanded, regardless of whether the patient is being treated on the ward or in the ICU. Slide 5. Empiric Therapy Architecture, General Medical Ward. For most hospitalized patients on a general medical ward, treatment consists of 2 major components. First is the beta-lactam backbone. Second is atypical coverage. Together, these form the standard regimen of a beta-lactam plus atypical add-on. Preferred options for beta-lactam backbone include ceftriaxone or cefotaxime. The atypical coverage is typically provided by azithromycin or doxycycline. If the patient cannot receive a beta-lactam, say due to allergy, an alternative strategy is respiratory fluoroquinolone monotherapy with levofloxacin or moxifloxacin. Pay particular attention to doxycycline. If there is concern for macrolide-resistant mycoplasma, especially after recent macrolide exposure, doxycycline becomes the preferred atypical add-on. Think of the beta-lactam as covering the typical pathogens and the atypical agent as closing an important diagnostic gap. Slide 6. Empiric Therapy Architecture, Intensive Care Unit. In the ICU, therapy becomes broader and more aggressive. Think of treatment as three pillars. Pillar 1 is the anti-pseudomonal beta-lactam, such as piperacillin, tazobactam, cefepime, or meropenem. Pillar 2 provides additional atypical and gram-negative coverage using levofloxacin, ciprofloxacin, or azithromycin. Pillar 3 is the MRSA add-on, either vancomycin or linezolid. The rationale is straightforward. ICU patients have the highest mortality risk and require broad initial coverage while diagnostic information is being collected. However, broad-spectrum therapy should never become permanent therapy. Once sputum cultures, blood cultures, and MRSA nasal PCR results become available, rapid de-escalation should follow. Slide 7. Navigating beta-lactam allergies. Not all reported penicillin allergies are equal. The first step is distinguishing between mild non-IgE-mediated reactions and severe IgE-mediated reactions. Patients with a simple maculopapular rash can usually receive third or fourth generation cephalosporins safely, including ceftriaxone, cefotaxime, and cefepime. The situation changes completely when there is a history of anaphylaxis, angioedema, or severe cutaneous reactions such as Stevens-Johnson syndrome or toxic epidermal necrolysis. In these cases, cephalosporins should generally be avoided. Alternative options include fluoroquinolone monotherapy with levofloxacin or moxifloxacin, or the newer agent omadacycline. Always clarify the allergy history before excluding an entire antibiotic class. Slide 8. The rationale for atypical coverage. Atypical coverage is not optional, it is a deliberate strategy. Beta-lactams effectively treat common bacterial pathogens such as Streptococcus pneumonia. However, organisms like Legionella, Mycoplasma, and Chlamydia are fundamentally different. These atypical pathogens cannot be reliably distinguished clinically or radiographically from standard bacterial CAP. This creates a significant vulnerability gap. Combination therapy using a beta-lactam plus a macrolide closes that gap. In addition, macrolides may provide beneficial immunomodulatory effects, which have been associated with lower mortality in severe CAP. The key phrase to remember here is complete coverage. Slide 9. Adjunctive corticosteroids. A common question is whether corticosteroids should be routinely prescribed. The answer is no. Patients with standard severe CAP who do not have shock generally do not benefit from routine steroid therapy. In fact, the harms may outweigh the benefits, including severe hypoglycemia, gastrointestinal bleeding, and secondary infections. The group that does benefit includes patients with septic shock requiring vasopressors and those with impending or early respiratory failure. In these patients, corticosteroids may reduce the risk of progression to ARDS and improve survival. The clinical rule is simple. Do not initiate systemic steroids for routine inpatient CAP. Reserve them for the crashing patient. Slide 10. The 48 to 72 hour reevaluation. Every patient should undergo a structured reassessment at 48 to 72 hours. Patients who are improving show resolving symptoms and normalization of temperature and white blood cell counts. These patients can begin planning for transition to oral therapy. Patients who are stable but not improving require continued observation. Consider non-infectious mimics such as pulmonary embolism or heart failure, and evaluate for complications such as empyema. The highest risk group consists of patients who are worsening. Look for rapid clinical deterioration, increasing oxygen requirements, or signs of sepsis. These patients need escalation of care, possible ICU transfer, repeat imaging, broader microbiologic evaluation, and expansion of empiric coverage. The reassessment point is where good clinicians separate routine recovery from impending disaster. Slide 11. The IV to PO transition. Transitioning from intravenous to oral therapy requires meeting several gating criteria. The patient should be clinically improving with less cough and dyspnea They should be hemodynamically stable. They must be tolerating oral intake and medications. Finally, vital signs and the white blood cell count should be normalizing. Once these criteria are met, intravenous therapy can be converted using the oral equivalency matrix. Patients receiving ceftriaxone plus a macrolide may transition to amoxicillin or amoxicillin clavulanate plus azithromycin or doxycycline. Patients already receiving a fluoroquinolone can generally continue with oral levofloxacin or moxifloxacin. Remember, the goal is not to complete intravenous therapy, but to complete effective therapy. Slide 12, duration of therapy. One of the most important aspects of pneumonia management is the duration of treatment. For non-severe uncomplicated CAP, therapy can often stop after 3 to 4 days, provided the patient is clinically stable and has been afebrile for at least 48 hours. For severe CAP requiring ICU care, a longer baseline course is usually necessary, with a minimum duration of 5 days. Patients with MRSA, Pseudomonas, or highly resistant gram-negative pathogens generally require at least 7 days of treatment. And remember this important clinical pearl. Do not extend antibiotics simply because the patient still has a cough or because residual infiltrates remain visible on the chest radiograph. Slide 13, Procalcitonin-guided de-escalation. Procalcitonin can help guide antibiotic discontinuation. Focus on 2 thresholds. If the absolute procalcitonin level falls below 0.25 nanograms per milliliter, concurrent bacterial cap becomes highly unlikely. In a clinically stable patient, antibiotics can generally be discontinued. When the initial level is very high, greater than 5 nanograms per milliliter, look for an 80% decline from peak value before stopping therapy. The important concept is trend interpretation. A falling procalcitonin level supports bacterial resolution and helps avoid unnecessarily prolonged antibiotic exposure. Slide 14, Discharge readiness and prevention. Discharge planning begins before discharge day. Patients should be hemodynamically stable, tolerating oral intake, and should not require overnight observation after transitioning to oral medications. Equally important is ensuring a safe environment for continued recovery at home. Discharge also provides an opportunity for prevention. Review vaccination status carefully. Consider seasonal influenza vaccination, COVID-19 vaccination, pneumococcal vaccination, and RSV vaccination when indicated. For smokers, provide smoking cessation counseling and appropriate pharmacotherapy before discharge. The admission may be ending, but prevention of the next admission starts today. Slide 15, the CAP inpatient master algorithm. Let's bring everything together. Start with PSI stratification and determine whether the patient belongs on the ward or in the ICU. Next, screen for MRSA and Pseudomonas risk factors. Ward patients typically receive ceftriaxone plus azithromycin. ICU patients require an anti-pseudomonal beta-lactam combined with levofloxacin and appropriate MRSA coverage. At 48 to 72 hours, reassess whether the patient is improving, stable, or worsening. If clinical criteria are met, proceed with step down to oral therapy. Finally, once the patient is stable, febrile for 48 hours and meets discontinuation criteria, including appropriate procalcitonin thresholds, stop antibiotics, and prepare for discharge. This pathway transforms CAP management from a series of isolated decisions into a structured, evidence-based clinical workflow.
This content is not intended for clinical guidance, use in medical clinics, or patient management. It serves as supplementary information for medical students preparing for examinations and should be used in conjunction with their official course materials. In the event of any discrepancies between this content and the prescribed curriculum, the curriculum shall take precedence until further review and clarification are made by the concerned students. The contributors to this video have exercised due diligence, but the content may become outdated quickly.